Hi, I'm Dr. Silva. I'm a board-certified psychiatrist, expert psychopharmacologist, and I specialize in devising psychotropic medication regimens and helping patients navigate those trials. I've been in practice a long time, nearly 3 decades, and so I've seen a lot of patients and I've helped thousands of individuals contend with their psychotropic medication regimens. Also, I myself have taken psychotropic medication. I suffer from OCD, and I'm in recovery from addictions, and so I've actually taken a lot of these medications myself. Psychotropic medications that change the mind, from the Greek tropos, meaning to turn or change. Changing the mind means changing perception, and changing perception changes reality. I want us to think about that for a second. Reality literally changes to the subjective mind. And because subjectivity is all your mind can ever know, all it can ever truly experience, reality literally changes. Anyone who's ever lost a loved one to suicide might understand this, that a person who commits suicide because of a major depression is living in a different reality than they would be if their brain were healthy. I know that's probably difficult for anyone who's never experienced that level of illness to fully grasp. It's truly mind-blowing. And by the same token, these medications can literally blow your mind. What could be more important than getting it right? Psychotropic medications change the way we feel, which changes the actual content of our thoughts. Our mood dictates the specific thoughts that arise in the mind, and people just, I don't think, truly understand that. Please see my video on the primordiality of mood for more on that concept. Also, you might check out my video on paranoia, my first-hand account of paranoia. I actually experienced a psychotic break as a consequence of my substance use, and so I was not only hallucinating, I was delusional, and I believed what I believed. I believed what I was seeing. It was right in front of me, but also it was more than that. So please check that video out. But the way we think and feel, of course, in turn, influences our behavior. Nothing could be more powerful, more potentially helpful, or by the same token, more pernicious. There are obvious pitfalls and there are not so obvious pitfalls, and if we don't navigate them successfully, then at best we entertain a series of inadequate therapeutic trials that are uncomfortable wastes of time and money, and at worst, they make us sick, emotionally and or physically, which is really saying the same thing. Emotions are physiological. They're based in neurochemistry. The year is 2025. A great many people have been prescribed psychoactive medication with the aim of changing their perception, and a great many more will follow all around the world. And in my experience, most of them have at one time or another undergone experiences that were at best unnecessary and even non-therapeutic. Most of them, at least those that I've met. Perhaps it's happened to you. If you're currently someone taking psychotropic medication or you're considering taking psychotropic medication, this is an important channel. What I'll say is that administering psychoactive medication is a true art that takes years to perfect. Because in as much as there's always more than one right way to do things, your provider should always offer you options, by the way. There are also so many pitfalls, so many places where things can go wrong, so much that in the wrong hands, patients can end up a lot worse off, unfortunately, as many of you know. So many inexperienced practitioners have trouble even simply properly identifying target symptoms, which you, as the patient, can help them get right if you yourself are properly prepared to participate in the collaboration that these trials represent. It's impossible to overestimate the role patients play in determining their target symptoms and their diagnoses, and in calibrating their regimens over time as they begin responding to the medication and reporting and dealing with side effects. And so it's absolutely vital that people know how to collaborate with their prescribers to get it right, to minimize adverse effects and maximize positive outcomes. There's so much to say on this topic. It goes well beyond the scope of a single video, obviously. But for those of you who are serious about becoming expert patients and making sure that you steer clear of those early pitfalls, huge and not uncommon mistakes that both patients and practitioners frequently make, I invite you to visit my online academy, Not on an Empty Mind. You can find the link in the description below. It will be well worth your time to check out my Gauntlet course, I promise you. That is a course. I hate to use the word course because, everybody's got an online course these days. They have a bad rep. Most people who actually take the plunge and buy a course don't finish it. People will start the course but this course is really a series of video presentations. Really what it is, if you subscribe to it, you will have lifetime unlimited access to every edition of this series of videos, and it's just going to get bigger and bigger as I add to it and refine it and expand it. I have OCD and I aim for perfection, and so if you want to know what my videos are like, please sample. I've got almost 200 here on YouTube, and here I give basic information that you can get if you Google enough. But I like to think that my presentations make it easier to digest, and that it brings all of the important must-know facts together in one convenient package. You could spend hours and hours trying to find this information online, and you still have to wade through the misinformation and the propaganda. But how could a layperson even identify that? Psychotropic medication trials can be punishing, but they shouldn't be, and they don't have to be. There are a lot of doubts, there's a lot of frustration out there, a lot of unanswered questions, and that's what I want to talk about today. That's what this video is about. Unanswered questions. Why do patients have so many? Especially in psychiatry. My opinion, because they don't know what to ask, especially those who are new to mental health. And so if you don't have a particularly forthcoming provider, the reason usually cited is a lack of time. If your provider doesn't offer answers to questions you didn't even know you had, then you don't even know what you don't know. It's a catch-22. So today I'm going to give you a glimpse of some of the things that you should be asking your provider. I sat down the other day, and in just under 5 minutes, I came up with over 60 questions just off the top of my head, each one exponentially begetting a series of follow-up questions. I actually counted, and there are 134 separate questions, but I grouped them into 60 questions and follow-up questions. But there are even more. And really, how could anyone know to ask about them all? In this video, I'm going to briefly talk about 3 that made the top 10, but if you want a list of the first 60, comment, give me the list below, and I'll send you a link for the free PDF download. Question number 1. And these are in no particular order, but this is the first question I ask myself whenever I meet a patient for the first time. Is the condition innate? I teach my medical students and residents that their first job in evaluating a patient and elucidating what's going on is to determine whether the condition at hand is endogenous or exogenous, i.e. innate and largely biological, perhaps genetic, but at any rate chronic and usually lifelong, versus largely situational, that is, well circumscribed and relatively transient when we consider a person's entire lifespan, provoked by life circumstances like an adjustment disorder. Is there something wrong in the central nervous system? That's my first question for trainees when they present a case to me. Is there something wrong with the brain? That's what I want to know. That's what I want medical students and residents. They should ask themselves that, and they should try to make a determination at the first evaluation. I teach all providers in training to ask themselves that question. Why does it matter? Why is the question important? Well, it confers a great deal of prognostic information, for one thing. It predicts a patient's future course a lot of the time. And if the answer to the nature-nurture question is that it has a lot more to do with biological factors than purely psychological ones, nature over nurture, that argues strongly in favor of using psychotropic medication, because the medication is more likely to be absolutely indicated as opposed to a relative recommendation. Like insulin and type 1 diabetes, some patients need medication. It's not optional, not if they want to be healthy. So that's always my number one question to myself. And it should be addressed early on, but this is a conversation many patients may never have with their providers. What you want to know, if at all possible, at the first visit is, have I had this condition all my life? Even if it didn't manifest until later, until adulthood. A lot of anxiety conditions aren't evident to the individual suffering them because they're lifelong. The implication is that if the condition is innate or endogenous, meaning born from within, then the problem is primarily a biochemical and/or neuroanatomical issue. and the need for medication is more absolute than relative. So how do you ask? Pardon me, doc, I have a question. Is my condition endogenous? You could ask that if what you've agreed to treat is something that you were born with. That's one way of asking. Do I have a condition, or is this just situational? And if so, was I born with it? And if so, why now? Why am I having symptoms now? A lot of clinicians don't necessarily even think in those terms, believe it or not. They don't necessarily, in their own minds, really make it that black and white and answer that question explicitly, not even in their own minds, much less for the patient. That idea of, is there something awry in the central nervous system? It may not make that much difference in the short term in terms of selecting medication and devising a treatment regimen to address the immediate target symptoms, but the answer to that question is of vital importance to answering example question number 2, will I have to take medication for the rest of my life? That's another valuable question that you should always ask your practitioner, whether it's at the first visit or whether it's subsequent visits. At some point, you should definitely ask that question, and it's probably going to come up, but you should really have a discussion around it. This goes back to the idea of whether the recommendation to submit to pharmacotherapy at all is relative or absolute. Inasmuch as your symptoms are expected to improve with the right medication, the question here is, are we correcting a pre-existing chemical imbalance, or are we simply targeting symptoms by manipulating neurochemistry, nudging the levels of certain neurotransmitters and hormones in the directions we want them to go because that's what's needed now to help cope with an external or exogenous stressor? It's a fair question at the first visit, but for those patients, anxious types, who ask me that before they've even taken the first dose, and I know there's great trepidation about submitting to treatment, and I'm almost 100% certain that the answer is going to be yes, that the patient should accept the need for indefinite treatment. A lot of times when the patients ask me that, all concerned, I'll usually say, let's get you feeling better first, and then I can help you decide. Because it's not a decision that patients are even capable of determining for themselves before they've started treatment. How can they, when they don't know how they're going to feel? They can't provide informed consent about lifelong treatment until they know what that treatment's going to do for them. It's going to do great good, or at least it has the potential to do great good if the treatment is administered cautiously and judiciously. Most people are loath to make a lifetime commitment at first blush. Who wants to take medication for the rest of their lives, especially psychoactive medication? Those patients need to be gently guided to a certain degree of acceptance. Some of the things that I cover in my course with these questions are considerations such as these. Not only what the questions are, but when might be the best time to ask them, even if it's only to prompt the doctor to start thinking along those lines. And importantly, what broad categories of answers you can expect to receive. So here's a question you should ask at some point, and here's what you might be told by a competent provider, so you can gauge the adequacy of the answer. That's something that's truly esoteric, and you're not going to find that Googling. There's no way. Here's what you should ask your provider, and here are the answers that your provider can give you if they're competent. Here are the broad categories, and their answer should fall into one of these broad categories, and here is how you can follow up on the answer. So you get an answer, and that should a good answer should engender follow-up questions. Why should a patient not be armed with that knowledge? It'll help you get better care. It will help you help your provider, who sees a lot of people and who's often very pressed for time. It will help you help the provider deliver the best care possible. If you want to receive good care, sometimes you have to meet the provider more than halfway. But if you're armed with some of this information, then you can help the provider give you the best care that provider is capable of giving you. It's just like a good candidate for psychotherapy that goes in and they've had lots of therapy, and so they know how to establish that therapeutic alliance and introspect and start. And however good the therapist is, they're going to get the absolute best care they can get from that therapist because they're also good psychotherapy clients. And so the same is true with the doctor-patient relationship or the patient-provider relationship. But that's harder for a patient to do. How can a patient bridge that gap? That gap, there's a lot of expertise that's not commonplace information. And my channel is geared at presenting a lot of that basic information, but it's in the application And that's something that takes making mistakes and learning from my patients and getting really, really good and writing a course so that people can have those amazing insights, including you providers in training out there. Question number 3, why did you choose this medication for me? Why Prozac? Why Cymbalta? Why not some other class of medication? That's usually a straightforward answer when you're asking about the entire class. Why an SSRI? Why an antidepressant? But even more esoterically, why not some other agent within the same class, within the selected class? So why Zoloft and not Paxil? That can be a tougher question to answer because so many practitioners often make those selections somewhat arbitrarily. They know they want an SSRI, they know they need to increase serotonin, and they just grab an SSRI. I did that when I first started prescribing. That shouldn't be the case. There should be a reason for everything. You should have a very specific reason for choosing a given medication, but maybe the provider doesn't have a reason. In the mid-90s, when I was a resident, there was Prozac, Zoloft, and Paxil. Those were the only SSRIs that were available. And I didn't know one from the other. I didn't know, really, I was so green, I didn't have any experience that I didn't have a sense for what would be the difference. And so I just picked one and prescribed it. And then I had patients come back. And through doing that over and over and over again, you began to see, oh, wait a minute, Paxil has a whole lot more sexual dysfunction. And a lot of people gain weight on it. And when they miss a dose, they go into physical withdrawal and etc. And it dries out the mouth more than Zoloft. Oh, and Zoloft causes a lot of diarrhea. Everybody that gets Zoloft gets diarrhea. At the beginning, I didn't know the difference between one or the other. And if a patient had asked me, well, why are you prescribing me Prozac and not Zoloft? I would have given them a blank stare. But now I can tell you precisely why. And there's a video, the Prozac family. Check out the Prozac family if you want to hear more about how the SSRIs differ one from the other. And are you taking the right one? Are you taking the one that maybe is best for you? Those are just a few examples of the kinds of questions that you might ask your provider. And as the provider gets to know you better and as the diagnosis is refined over the course of several visits, the answers themselves may evolve and become more complex and typically, as I said, inspire a host of follow-up questions. That's how you know when you're on the right track. Also, depending on your particular response to early treatment, the conversation, the ongoing dialogue that you have with your provider in terms of the Q&A gets more and more refined, more and more about your specific needs, your specific experience. And so again, I just picked 3, but if you want the list of 60 most important questions I could think of, leave a comment below, or you can always email me directly at drsilva@drsilva.com. The videos in my Gauntlet course that covers the top questions that you need to ask is going to take a deep dive into all 60 of the most important questions, kind of like what I've done here with these, but maybe even a little bit more comprehensively, explaining why the questions are important. Not just ask this, but to tell you what the implications are, why the question is important, what information it gives you beyond just the specific answer, because the specific answers are going to vary. But here's this question, and this is why it's important, and it also examines the questions from both the perspective of the patient and the clinician. Invaluable information, actionable knowledge. Thank you for listening. As always, questions and comments are welcome.